So we are. It's kind of like a hot and humid, hard to survive. But anyways, we don't have much of like a theoretical thing to cover today. We already have finished like the development of the neck, which comes with these developing content with the pharyngeal apparatus. We learned about the arches, pouches and the cleft, and all three together contributes to the formations of the neck structures. Whatever the content that you have, muscles, bones, ligaments, soft tissue structures related to it, ears, ossicles, etc., etc. Now, once we have covered this, we have to cover the other content of this particular developmental source of organs like a tongue and thyroid. These are the two important topics for us to understand, because they are clinically important, and as well as we see the clinical questions coming. So, the clinical question we see that last time coming is the development of the thyroid gland, and that particular development of thyroid gland error is one of the areas what we have to differentiate between the other error of developmental problems arising in the neck region. So, we will be coming into it. So, two topics to cover today is that we are going to cover these development of the tongue, which is easy in a sense, don't have to bother much, and again is more important is that the development of the thyroid gland and the error of the thyroid gland development, that is important to us. So, no. So, this tongue which develops from the floor of the developing mouth. So, we have seen this particular foregut region, midgut and hindgut. So, this particular foregut region where this future neck region is developing, which comes with this some kind of like a undulation, we call them as pharyngeal arches, in between them we have the clefts. So, if you consider this particular developing foregut as a tube or lumen thing which is present within this particular tube, that means a hollow tube, inside of that particular tube where this particular future mouth is developing. So, this particular future inside of this particular developing mouth, which corresponds with the developing arches, we have some kind of prominence appear. That particular prominence which are in numbers, like right side, left side, midline, and they come in front to back in series. Now, this particular elevation is kind of like an endodermal elevation. So, we understand this ectoderm, we understand this mesoderm, and we understand this endoderm. That means inside this particular mouth cavity where we have this particular pharyngeal pouches developing, and that particular region we have this particular mouth developing. So, this is a split open region of this developing foregut region, which is a cranial most part. We have these arches developing, and if you cut open, you see that there is a developing tissues which is coming in here. So, this cranial most part, we have this tongue which is coming, then we have this particular region which is corresponds to this particular tonsil, tonsillar bed, now larynx, so on, this is going on. So, we are going to start with this particular phenomenon where this particular tongue is coming or developing in sequence. So, do not have to wait much. So, this is what you are seeing, this ectodermal side of the developing embryo cut here. You have seen this particular thing cut, and you are seeing from the top, and inside the cavity of this particular foregut lumen, this looks like this, and here we see that corresponding to the arches, we have a midline elevations or bulges which are present. Now, this midline elevation and bulges gives rise to the developing tongue. That is what we are going to talk. So, this is what we have started with. The tongue develops from the floor of the mouth or developing floor of the mouth swelling. So, there are two swelling or elevation that is developed in the floor of the mouth region related to this particular first arch. We call them as lateral lingual swelling. So, this is what we have learned so far in the previous sessions, previous classes. We will be coming again, once again, related to the clinical problems. So, this is what we are seeing here. This particular thing, we are seeing the lumen cut open and split, and then you are seeing this particular elevations which is going to form our tongue. So this is what we have, this endoderm, that means mucosal element, which is correspond to this particular first arch. As you can see, right side and left side, there are two bunches there. This bulge which is present, we call them as lateral bulge, and this is going to yield the tongue. We call them as lingual bulge or lingual bud. We call them as lateral lingual swelling or lateral lingual bud. So there are two of them, right side and left side, right lateral, left lateral. Again, little bit downwards towards this, arching over the developing second arch, you see that again a mucosal bulge is there, which is present in the midline. This midline elevation we call them as Tuberculum Impar. So these are the three elevations, right, left and the midline, present in the floor of the mouth or developing region, which is sitting in this region. Tuberculum Impar is encroaching on, as you can see, on the second arch. Now this is important, as I mentioned, it is encroaching towards the second arch. Now then we have another swelling, which is this one, is a midline vague swelling which is present and running between the arch number 2, 3 and 4. And out of these 2, 3 and 4, this one, third arch, it takes the maximum swelling. So this particular swelling which is present in this region, we call them as Hypobranchial Eminence, also in a word we can call them as Copula. So these are a swelling which is present again midline, little bit down, related to the second arch. So we have come again to number of elevations or bumps. Two of them laterally present, right and left lateral lingual swelling, a midline swelling, next to it tuberculum impar, and then they are more or less correspond to this arch number 1 and encroaching towards the arch number 2. Then on this second and third predominant arch, which is contributing the mucosa over there, is making another bulge, we call them as copula or hypobranchial eminence. Then if you go down, correspond to the fourth arch, we have another elevations over here. So this another elevation which is present in here, we call them as epiglottal swelling. So this midline swelling, lateral swelling present within cavity of this developing floor of the mouth, going to yield our tongue. So these words are different or difficult to memorize, but if you make it in a simple way, we divide this particular tongue into two parts. Whenever you are going to talk this particular tongue, in terms of narrating it in a gross, we call them as tongue is divided into two basic structures. We call them as anterior 2/3 of the tongue and posterior 1/3 of the tongue. And then we have this posterior most part of the tongue where the tongue is anchored to the pharynx or the deep down. So this tongue is free in the anterior side and anchored to the back side or posterior side. So this tongue can be divided into anterior 1/3 or anterior 2/3, posterior 1/3 and posterior most part of the tongue. These are the three things. Now out of these three things, in between this anterior 2/3 of the tongue and posterior 1/3 of the tongue, we have a limiting line. We call them as sulcus limitans. And the center of the sulcus limitans, we have a depression. We call them as foramen. We call them as foramen cecum. So if you just like a look in the gross feature of the tongue, it has got these features. Anterior 2/3, posterior 1/3 and separated by a line, we call them as sulcus terminalis or terminal sulcus, which is a V-shaped structure, and that particular structure splitting the tongue anteriorly and posteriorly, and then tongue is anchored to the back side towards the pharynx side, where we narrate that part of the tongue is posterior most of the tongue. So tongue has got three parts, anterior 2/3, posterior 1/3 and posterior most or fused or anchored part. Now out of these 3 or 4 swellings that is present, they are going to produce the mucosa of this particular tongue. So they are going to create the mucosal layer, that means the outer layer of this particular tongue. Now within the tongue, we need some muscles to get in. So within this mucosa, we need to infiltrate some muscles. Those muscles of the tongue are sourced from somewhere. They are not coming from this endodermal swelling. So the muscles of the tongue are come or comes from a different source, we call them as occipital myotome. So, where is the occipital myotome? This is a developing embryo, as you are seeing, a kind of like a age which is around like 34 days. You see that this particular developing embryo have got some kind of rib-like structure present. So, this rib-like structure which looks like a block of this vertebra, we call them as somites. Now, these somites present from this back of the skull to this particular tail region. So, this somites out here, the most cranial most part close to this particular like a skull bone or close to this particular neural element, this region we call them as somites, as occipital somites or occipital blocks. Now, these occipital blocks are numbered from 1 to 6, number 1, number 2, number 3, you can count this as well, these blocks or somites. So, these blocks which is present in the back side, we call them as occipital somite. Out of these 6, second, third, fourth and fifth somites, they contribute to the muscles of the tongue. So, the muscles of the tongue is basically traveling from the back of the neck to this particular trunk, migrating and settling within under these undulations on this region. So, this mucosal bulge are there, it is created. Now, this particular bulge within this, there is migration of the somite cells. The somite cell brings the mesenchymal cells. That means they are producing to form this muscle cells. In the tongue, we have two set of muscle. We call them as intrinsic muscle and extrinsic muscles. They are coming from inside the tongue and elsewhere they are coming, like glossy or anything which you are seeing here, genioglossus, styloglossus, etc., etc. These are the muscles of the tongue. If you see the word glossy against to the names of the muscle, they are linked to this particular tongue. So, this glossy muscle or whatever the things that is related to the glossy, and again there are some muscle which is present within the tongue substance, we call them as horizontal fiber, transverse fiber, oblique fibers of these muscle fibers of the tongue, they are present within this thing. So, all this muscle group, intrinsic and as well as extrinsic, coming from the occipital myotome 2 to 5, migrating from the back and slowly getting through this particular mucosal elevation and sitting there. Now, these muscles, once they are fitting in here, this particular elevation they fuse. What do they do? This particular lateral elevation, lateral lingual elevation, right side, left side, with this particular elevation we call them as tuberculum impar, this mucosal bulge, they fuse. They fuse to form the anterior 2/3 of the tongue mucosa. We are left with other mucosal elevation, we call them as copula or hypobranchial element. This hypobranchial eminence, that mucosal elements flattened after this with these migrations of these particular muscle cells forms this posterior third of the tongue. So, this anterior third of the tongue and the posterior third of the tongue, they are formed by these fusions of this bulge with permeation of muscle cells, they are coming or migrating from occipital myotome. Now, the catch is that the occipital myotomes are producing all the muscles that are present in the tongue. And for the occipital myotome, we have a dedicated nerve. The dedicated nerve for the occipital myotome is the 12th cranial nerve. So, that is why all the muscles of the tongue except one is supplied by the 12th cranial nerve. So, that is the reason of why this particular muscle or all the muscles of the tongue is supplied by the 12th cranial nerve, because they are sourced from this occipital myotome. Just like this pharyngeal arches, they have the dedicated nerve supply to it. The dedicated nerve supply to this particular occipital myotome muscles are 12th cranial nerve. So, all the muscles of the tongue is supplied by 12th cranial nerve except one. Alright, we call them as styloglossus, palatoglossus, whatever the muscles are there. We are not going to break down this particular tongue muscles right away, but we are just mentioning all the muscles of the tongue is supplied by 12th cranial nerve. That means the motor supply, the movement of the tongue is supplied by 12th cranial nerve except one. We will talk about the except later. So, this is how this particular tongue thing is formed. So, this particular tongue which is formed in the floor of the mouth, through this elevation or fusions of the elevation forming anterior 2/3, posterior 1/3 and posterior most part of the tongue is formed by the epiglottal swelling which corresponds to the 4th one. Now coming to the complex thing. Now why this particular tongue have got so different innervations in terms of sensory, motor and spatial sensation, which actually comes with this particular logic. Now you see that the epithelium of the tongue is having two characters. That means it can pick up the sensation, that means touch, pain, temperature. If you are drinking hot coffee or cold ice cream, we feel that this is a cold or hot thing. That means it's a general sensation, touch, pain, temperature. If we are biting the teeth, we are feeling the pain. That means it's a general sensation. At the same time, we have a gifted special sense which is appreciated by the tongue, the taste of the food. It's sour, it's sweet or any kind of bitterness, whatever the nature of the food is there, we can sense it. So the tongue is having two kind of sensation, gifted with two. One is general sensation, touch, pain, temperature thing. Other is special sensation, how do the food look like. So that particular element, it has a dual action. And for this dual action, we have a different nerve responsible for carrying this sensation. And again, the tongue has got muscles. To move this particular tongue, we have the muscles to move. So the muscles are supplied by different nerves as well. So tongue is supplied by the 3 sets of nerves, and that is confusing thing during examination, during the interview or during these MCQs, we often forget about. So to make these things clear, so first we take this particular general sensation, touch, pain and temperature sensation, and that too is different from this anterior third of the tongue and posterior third of the tongue. We take this particular spatial sensation, that means the taste sensation from the anterior third of the tongue or posterior third of the tongue and posterior most part of the tongue as well. They are also picked up by different nerves and muscles. So the most easy thing about this particular tongue is that the innervations of the muscle, which is the easiest thing. So muscles of the tongue coming from occipital myotome, they are all supplied by 12th cranial nerve except one. We drop this except one for this now. So all the muscles of the tongue except one is supplied by motorily by 12th cranial nerve because they are coming from occipital myotome. And we understand occipital myotome is a vague area behind this particular back side of the individual of individual embryo which migrates and settles within this mucosa. Now we split it down to this particular general sensation from the anterior third of the tongue and general sensation of posterior third of the tongue. The general sensation of the anterior third of the tongue is carried through V or trigeminal nerve. The general sensation of the posterior third of the tongue is carried through the cranial nerve number 9. So we have two nerves to cover over here, the epithelium over anterior 2/3 of the tongue. That means it is coming from the touch, pain, temperature. It is coming from the mandibular divisions of the lingual nerve. That means it is the trigeminal nerve. So the epithelium over posterior third of the tongue, which is supplied with general sensation coming from cranial number 9, that is glossopharyngeal. Why? Because this posterior third of the tongue, you see that develops from this region. We call them as copula. This copula gets maximum contribution from the third arch. And what is the nerve of the third arch? Which is a trigeminal nerve. It's a glossopharyngeal nerve. So that's why this particular region have an innervation, general sensation is coming from here, which is coming from this third pharyngeal arch corresponding it glossopharyngeal nerve. And in case of this anterior third of the tongue, majority of it is contributed by this first arch. First arch nerve, we know that it is coming from the 5th cranial nerve. So this particular general sensation of epithelium of the tongue, anterior third, which corresponds to the first arch, is coming from the mandibular division, which is coming through a branch, we call them as lingual branch, which is a branch of trigeminal nerve. Whereas this epithelium of posterior third of the tongue, which is coming from, corresponds to the third arch, is supplied by the cranial nerve number 9, glossopharyngeal. This is one thing, general sensation, touch, pain, temperature. Now the spatial sensation of the tongue, that means the smell and as well as the taste. Now this anterior third of the tongue, which is coming or getting this particular sensation of special sense, is coming from this particular derivative which is encroaching here with the second arch derivative, which is facial nerve through the branch chorda tympani, supplies this tongue buds. That means this tongue has a special sensation, which is that taste which you are picking from the anterior third of the tongue is carried through the facial nerve branch chorda tympani to this particular higher centers. Likewise, this particular posterior third of the tongue, the special sensation, that means that particular taste sensation is carried through the same cranial nerve which is arching over the third arch, which is going through the glossopharyngeal nerve. So this two demarcation of sensory sensation and the special sensation are your exam question, and it's kind of 50% or more than 50% cases we get the wrong answer without reflecting it properly. So if you are not clearing these things out during examination, you will fail to answer it with 100% accuracy, and it's a guaranteed fact. So this general sensation of the tongue, anterior third, general sensation of the posterior third, special sensation of the anterior third, special sensation of the posterior third of the tongue, and as well as the motor supply of the tongue, they are very confusing unless until you focus on and study all these details of it. Now, other than this, the posterior most part of the tongue, which is lying or anchored in the back side, so that epithelium of the posterior most part of the tongue, which corresponds to this particular fourth arch, which is lying in here, we call them as epiglottal swelling. The mucosa is taken or taking a bunch from this particular fourth arch. The fourth arch is supplied by the vagus nerve, superior laryngeal nerve. So this particular taste sensation, if it is present, and as well as general sensation, if it is present, which is taken from this particular posterior most part of the tongue, is coming through the superior laryngeal nerve branch of vagus from the both of these particular domains. So this particular chart is a kind of house for 10 to 15 MCQs. You can frame these 10 and 15 MCQs based on these particular charts with different kind of projections, creating clinical questions, clinical scenarios. We can say that there is a person who has a tongue cancer on the lateral third, on the anterior portions of the tongue, and you want to anesthetize, which particular nerve will be picking up. And again, with the same situation, we can frame it that you have done a surgery to that particular anterior third of the tongue, partially removed, and that particular person from the anterior third of the tongue cannot feel any taste sensation. So which nerve probably is excised during this particular surgery of that particular tongue, which is not picking up the taste sensation from the anterior third of the tongue, and likewise this particular posterior or posterior most part of the tongue. So from this particular chart, we can go to any tangential directions to frame clinical questions regard to this particular tongue. So this particular tongue comes with the swelling, which is the gross part. You do not have to memorize detail of that, but the problem is if you just do not remember the detail of this particular bulges or elevation, you cannot remember this particular elevations of this epithelium, and you cannot remember this occipital myotome, how these things are coming. Now, once you have formed this particular tongue, as you can see, this particular tongue, anterior third and partly posterior third of the tongue is free from floor of the mouth. So we can move the tongue to any direction. You can touch this particular hard palate, soft palate, move to the right, left side over there. So this particular tongue, the under surface need to be freed from the floor of the mouth. So we have this mouth floor, and from this floor of the mouth, the anterior third of the tongue need to be freed, so that this anterior part of the tongue is free. To make this particular tongue free from this particular floor of this mouth region, we need some kind of apoptosis or degenerations of the cell. So once this particular tongue is formed, as you can see, this particular tongue is formed like this, it need to be freed from under surface. So you have to just like free the tongue from bottom, so that tongue can be moving up and down, right and left. So that freeing of this tongue from the floor of the mouth is done by the apoptosis or gradual degeneration of this tongue between the tip and the base. So between the tip and the base, these tissues need to be degenerated. Now if it fails to degenerate, we have a string-like structure tagging this. So we call this string-like structure, which is tagging this floor of the tongue, floor of the mouth to the undersurface of the tongue, we call them as tongue tie. So this tongue tie leads to a partial or complete fixation of the tongue with the floor of the mouth. So some of the individual may have this particular tongue tie complete. That means they are not free from this particular lower part. So tongue is moving but partially moving. And they may have a small tag, that means that allowing more mobility, but still it is a tag tie. So this particular thing where this particular tongue is not freed from this floor of the mouth, where this degeneration or failure cellular degeneration between the tip of the tongue and the floor of the mouth is not happening, is leading to formation of the tongue tie. Now, apparently it looks like it's not a big deal, but during examination they give the choices, like a person coming with a tongue tie, and what is the cause of the tongue tie, and 100% of the chances are there we fail to identify the right causes. The right cause of this particular tongue tie is that failure of degeneration of the tissues, which normally should get damaged or destroyed between this floor of the mouth and the tongue, leading to this tongue tie. So this particular word matters to us is degeneration of the cells which is present between this particular floor of the mouth and the tongue, which leads to formation of a tag like this, or which is lined by the mucosa. We call them as tongue tie, and other word of the tongue tie is that ankylosing. So this is an element which is important to us. Now coming back, we are going to talk about the next development, the de-development of all organ which is present in the neck region. We call them as the thyroid gland. Now, to know the development of the thyroid gland, again we have to come to the development of the thyroid of the tongue itself. Now tongue develops from two sources from this floor of the mouth. It divided into two parts, rather three parts if more precise. So it has anterior third, anterior two-third and posterior third. And in between this anterior two-third and the posterior one-third, we have a groove existing. We call them as sulcus terminalis, also known as terminal sulcus. Now this sulcus terminalis looks like a V separating between anterior two-third and posterior one-third. Now this particular V meets in the midline over here strictly. So the point where this particular sulcus terminalis meeting in the midline, that particular point we call them as foramen cecum. Now why do we call them as foramen cecum? Because there is a foramen which is present. We have foramen cecum elsewhere in our body as well, but this one we call them as foramen cecum of tongue. Now what is a foramen cecum? We have a depression here where we have this particular union point of the anterior two-third of the tongue and posterior third of the tongue. This then this is visible. If you just check yourself in front of the mirror, shine some light, see that the tongue here in the midline, you can see the foramen cecum. It's a kind of midline, a circular or semicircular dot that is present. So this particular foramen cecum, which is present at the junctions of this anterior two-third and posterior third of the tongue, is the story where from the development of the thyroid develops. So this is what we are starting with, the thyroid gland development. The thyroid gland develops from this tongue. Which part of the tongue? The foramen cecum. The mucosa, the endoderm which is present at that foramen cecum, that creates a depression and it goes down as a hollow trench. So that particular tongue, as you can see, this is a tongue schematic picture, of course. This is a tongue, this is a teeth which you are seeing here. This is posterior third, this is anterior third, and it is split between them. We have this foramen cecum present in here. What is a foramen cecum? This mucosa which is present in the midline where this particular sulcus terminalis is meeting. Now this particular foramen cecum is going under and under. So this endoderm or this particular tissue which is cells which is present in here is making a groove or making a tunnel and going under or penetrating the under surface of the tongue mucosa, and it is going down. Now this tongue is growing with the muscle, where from the muscles are coming? The occipital myotome. So on the back side the muscles are coming, and as a result of that the tongue becomes heavy. So as this tongue gets heavy, it pushes this foramen cecum dent into more and more, it buries down. So this particular narrow thing or narrow foramen cecum, which was a tiny slit, slowly get pushed down because of the growing tongue muscles, and it is pushing down. So, and that creates a trench-like tract. This tract, we call them as thyroglossal duct. We call them as thyroglossal duct, which contains these cells of the foramen cecum. And that particular thyroglossal duct, you can see that slowly go down to the, goes to the anterior border of the neck region, finds the midline, and once it finds the midline, go down further. In this region, we find a developing bone over here. We call them as hyoid. So it crosses the hyoid, goes under to it, and then it takes a rest for a while. Then again it goes down to this, find this particular cartilage developing. This is the larynx or voice box developing. It goes down the larynx through the push or pull of these particular tissues. So this thyroglossal duct, which is going down to the subhyoid, to this particular sublarynx, and then settle down to this particular trachea. So once it finds this trachea in the midline, it sets there. That's the final position. No more signal is present at that point. After that, this thyroglossal duct expand into right lobe and left lobe, and joining by a midline thing, we call them as isthmus. So this is how this whole story begins. So thyroid gland develops from the endoderm of tuberculum impar. Between that part, we call them as this foramen cecum, which is present between the anterior 2/3 and the posterior 1/3 of the tongue. And then we create the tract. That tract we call them as thyroglossal duct. Now this duct goes down subhyoid, sublarynx, and settle down to this particular trachea, and then it splits into two parts, right and left, joined by a single thing. We call them as isthmus. And then what happens once these things are settled over here, full grown thyroid tissue is formed. This thyroglossal duct, which is making the tract, entire tract, vanishes. So this is a guiding thing or the trench. Once this thyroid gland is formed, this entire tract or this thyroglossal duct completely vanishes. So this is how this whole thyroid gland is formed, starting from the foramen cecum, subhyoid, sublarynx, and to the trachea. So this is how it is going, strictly in the midline. That's the what we have to carry. Now, if we do not have that regression of thyroglossal duct, that means that trench that has been created, if it is not there, if it is failed to vanish, it creates a cyst, just like a cyst we talked about yesterday. We call them as lateral neck cyst. We call them as branchial cyst, right? So if that particular similar kind of thing, we have this particular thyroglossal duct, that tract fail to disappear, we create a cyst. That particular cyst is strictly present in the midline, where this thyroid gland is going down, or how this thyroid gland is going down. Within this particular tract, we find the cyst. Now that particular cyst, if it is created, we create with this kind of swelling. So this is how this whole thing is going to be tested in examination. So see this particular clinical picture. It's a young boy, say for example 10 years of age, coming to your clinic with your midline swelling, and this particular strict midline swelling has not associated with pain or tenderness or anything, and it is slowly evolving, growing in size, with starting to visible become 5 years of age, and presenting age is 10. Between that time, it has grown from a tiny seed to this particular small tennis ball size, ping pong ball size, and this particular swelling has a particular pattern. This particular swelling moves up with swallowing. So if you ask the patient to swallow, this particular movement, this particular swelling moves up or down. Second thing, if you ask this patient to stick out the tongue, say ah, this movement of this small size nodule goes up and down. So this is the clue that you have to see. So this is the clinical case. In the last year supply we had it. 0% that made a right answer to it. So this midline swelling had the same clinical feature that we have mentioned, has two elements to be noticed over here. Moves up and down with swallowing or deglutition, and as well as moves up and down if you stick this particular tongue out. Now you have to explain why this particular swelling moves up and down with swallowing, and why this particular swelling moves up or down if you stick this tongue out. Now I am not going to tell that for you. You have to find it out, sort it out or ruin. So this particular element we call them as thyroglossal duct cyst, a sticky midline cyst. It is formed by the remnant of the thyroglossal duct cyst which fails to regress and leading to a swelling which is present strictly in the midline, moves up and down with the movement of this deglutition and as well as sticking up of the tongue. Now this is what we call them as thyroglossal duct cyst. Now other varieties of persistence of thyroglossal duct. So if we have this particular thyroglossal duct which is present between this part, from this particular part we call them as cranial part to the caudal part. So if the cranial part of the duct is absorbed, completely damaged or completely vanished, no problem. If the caudal part which is close to the isthmus is failed to regress, it can create a thyroid tissue. We call this as pyramidal lobe. So the pyramidal lobe anatomy or embryology also been tested in examination. How this particular pyramidal lobe can be emphasized or can be explained through embryological knowledge. So this is one thing. Other thing is that, as we have seen, this thyroid gland is developing from this tissue which is coming from the foramen cecum, and this particular thyroid gland goes down, decides to migrate. Now if this thyroid gland do not migrate at all, it sits there where it is there. That means it sits at that particular foramen cecum, and that particular foramen cecum region grows into thyroid gland. Now what is going to happen to that case? The patient we have the thyroid gland on tongue. Where on tongue? The junction of anterior 2/3 and posterior third of the tongue. And that particular condition we call them as aberrant thyroid tissue. So aberrant thyroid tissue can be anywhere, any place. If this migration is slow or not happening at all. Not happening at all, lingual thyroid. That means on the tongue the thyroid gland is there. And if it is slow in migration, it may be arrested in the movement track where it is going, at the hyoid bone or subhyoid bone or larynx or laryngeal regions, etc., etc. So during this particular normal track of the midline path of thyroglossal duct, this particular thyroid gland may be arrested at any point. So depending on where it is arrested, we call them as aberrant thyroid tissues. If it is stuck in this tongue, we call them as lingual thyroid. That's a kind of very weird case where we see this particular person presenting the clinic, a swelling or growth or tumor on the junctions of anterior 2/3 and posterior 1/3 of the tongue. And you see that the case and diagnose it wisely. Oh, you have a very bad tumor in the tongue, let me operate it out and scrap these things off. Then during this biopsy you find that this was a thyroid gland, and that was the only thyroid gland that the patient has.